absorbed through the receptor within the ileum. So the B12 uh, combined with intrinsic factor and absorb in the ileum, which is the part of small intestine, and then um, folic acid. It's absorbed in the form of methyl tetrahydrofolate and the duodenum and jejunum, and transport into the blood and ultimately into the bone marrow per the cellular activity and uh, nucleus formation. So megaloblastic anemia is there are multiple causes, and it's caused by defective DNA synthesis, such as vitamin B12 deficiency, which also known as pernicious anemia, and that could happen due to the gastrectomy or vegan diet. The people who don't eat meat are more prone to vitamin B12 deficiency because it's one of the richest source of vitamin B12. And then folate deficiency, the causes could be poor diet, pregnancy, drug like different drugs such as methotrexate um, could also, cause the folate deficiency. So here you can see that how it's affect the DNA synthesis and then the cellular lobe formation. So we need, mm, folate for the tetrahydrofolate for certain reaction when homocysteine is converted to methionine. And here in the top you also see, and this methionine is converted acetoinosine methionine, and it's required for the myelination of nerves as well as methylation of DNA, amines, and protein. So it's really important to have tetrahydrofolate or vitamin B12. It's also required for these kind of reaction. In addition to that, it's also required for the formation of DTP, which form DNA. So if there is deficiency of folate or vitamin B12, it could, cause demyelination or, impaired DNA formation. In this kind of anemia, you will see large precursor of RBC due to, late maturation of the nucleus. Uh, and clinical features such as fatigue, failure skin, jaundice, as well as glossitis, and neurological symptoms can also be seen in vitamin B12 deficiency, such as ataxia. And there, how to investigate the CBC will show low hemoglobin, high MCV, normal or low retics count, and as well as normal MCH and MCHC. In the blood film, you will see macrovillosite, hypersegmented neutrophil, because if there is impaired DNA formation, so the cell will unable to make proper lobe, so you will see hyperlobulation in neutrophil. It's one of the characteristic feature of megaloblastic anemia. And then bone marrow hypercellular with megaloblast. In the treatment, is a hydroxycobalamin injection and folate deficiency, oral folic acid um, are, but you have to exclude the cause of um, B12 deficiency first, and then advise the patient oral folic acid. So in this picture, you can see on the right, there is a blood smear, but you can see here, hypersegmented neutrophil 1, 2, 3, 4, 5, 6 lobe within this cell, as well as on the left, you can see another hypersegmented neutrophil here as well here. So it's and you will see ovulocyte. You see that the cell are bigger in size as well as look like a little bit oval in shape. So it's a characteristic of megaloblastic anemia. You will see hypersegmented neutrophil. Then normocytic normochromic anemia, there is multiple causes such as acute blast, anemia of chronic infection, aplastic anemia, and early hemolytic anemia. And there are chronic diseases which induce hepticin-mediated iron sequestration and reduce erythropoietin production, acute blood loss such as reduce RBC count but normal size and color. So erythropoietin is basically a protein which produced by kidney around 90% and 10% by the liver to and responsible for the production of RBC. But certain chronic diseases, it's inhibit the or reduce the formation of erythropoietin, which lead to this kind of anemia, and the symptom are similar to the symptom of general anemia, as we have discussed earlier. So in the CBC, you will see low HB, normal MCB, and MCHC, MCH, um, uh, as well as MCHC. In the blood film, will show normal RBC, malformative reticulocyte, low in hypoproliferative state, high in hemolysis. So we have to find out the cause, either erythropoietin, low erythropoietin, or due to the acute transfusion reaction or any other cause. So you have to find out the cause and then treat accordingly. Then hemolytic anemia, there are two type of hemolysis. One is extravascular hemolysis and intravascular hemolysis. The extravascular hemolysis take place in reticuloendothelial system, and it's generate after the lysis of RBC within the macrophage. It produces amino acid which is reused by the body, and iron which bind to transferrin and reuse in the body, while the protoporphyrin is converted to bilirubin, and bilirubin bind to the albumin which is delivered to the liver and conjugated with glucuronide transferase. So the conjugated bilirubin are water soluble, and which can absorb through intestine, and um, it can pass through the kidney as a urobilinogen, and you will see increased level of urobilinogen if there is an increase in extravascular hemolysis, and the rest is excreted through feces is stercobilinogen, which give brown color to the feces. So in intravascular hemolysis, there increase lysis of the cell, you will see hemoglobin, and hemoglobin filter through the kidneys, and you will see hemoglobinuria. So how to differentiate between extravascular and intravascular hemolysis? And intravascular hemolysis, you will see hemoglobinuria, while in extravascular hemolysis, you will see urobilinogen, increase in the amount of urobilinogen in the urine. There are multiple causes. Some of them are heredity, as I have mentioned, were here, and some are acquired. I don't want to go into detail at this stage, but you should remember at least these causes. In the laboratory firing, you will see increased serum bilirubin level, unconjugated and conjugated, increase in urobilinogen level, and serum heptacidin will absent, because heptacidin bind with the hemoglobin, and then it's removed by reticuloendothelial system, and then reticulocytosis and bone marrow erythroid hyperplasia. The normal bone marrow myeloid erythroid ratio is 2.1 to 12.1, is reduced to 1.1 or reverse, right? So damage to red cell. So there could be the hemolysis could be due to the different condition in which the cell membrane is abnormal, such as microspherocyte, elliptocyte, or uh, fragmented fragmented RBC. So you will see this kind of uh, cell in the blood or fragment of RBC if there is more hemolysis. And then we have certain tests such as osmotic fragility test, which we use to rule out the cause of the red cell membrane diseases, and specific enzyme, protein, and DNA test could be used to diagnose specific cause. So this is very important to remember. There are some remnant within the red blood cell, such as nucleated. You can see Hall jelly bodies, which is basically DNA remnant, and we see it in different diseases, anemias, for example, and pernicious anemia. You will see these kind of remnant within the cell. Then basophilic stippling, you can see diffusely blue color stain, material within the cell, and these are able to stain with the basic component of the stains. So these can be seen in uh, mm, uh, certain situation, such as thalassemia and lead poisoning. Then you can see sideroblastic granule, which is seen in the sideroblastic anemia, and it's also called PP Hemar bodies. And this we can stain with the Prussian blue stain, and then malaria parasite, reticulocyte, uh, mm, which having RNA remnant, and we stain them with clear, crystal violet or brilliant chrysal blue, and Heinz body, which is denatured hemoglobin. We see in different hemoglobinopathies such as HBS disease, HBC disease. Then I put a slide about the morphology of cell. It's very important to remember these because it's it's important for the disease diagnosis as well as for the treatment. So macrocytic is can we can see it in the megaloblastic anemia, liver disease, alcoholism, then target cell, iron deficiency anemia, hemoglobinopathies, and post-ilectomy, stomatocyte, liver disease, and alcoholism, and pencil cell, which is the main characteristic of iron deficiency anemia. Then fragmented RBC, you will see in hemolytic uremic syndrome, DIC, TTP, and so on. So there are multiple causes I have put over here, so you have to remember. And then microcyte iron deficiency again. Then I put a summary table to summarize, the disorder as well as their mechanism, CBC result, peripheral finding, peripheral blood finding, retic count, and then bone marrow finding, and what are the diagnoses we can use to diagnose a particular disorder. So iron deficiency anemia, it's more common, and you will see decrease MCV, MCH, MCHC, increase in RDW, decrease serum iron, um, and ferritin level, increased TIBC and transferrin receptor, then anemia of chronic disorder. So you have to differentiate between iron deficiency anemia and anemia of chronic disorder. So you will see decreased iron um, uh, in saturation and TIBC, and mainly increased ferritin. So here you can see um, also here you can see decrease in the ferritin level, but anemia of chronic disorder you will see increase in the level of ferritin. So normal transferrin receptor, but in iron deficiency you will see increase, and here you will see increased storage of iron. Then sideroblastic anemia, so you have to remember increased serum iron, ferritin, and saturation, normal to decreased TIBC and transferrin receptor, increased storage of iron, and vitamin B12 deficiency, in which you will see increase in MCV and RDW, progressively decrease in WBC and platelets, and decreased serum B12. So in the hypersegmented neutrophil is one of the characteristic. In a blood picture you will see how jelly bodies as well as hypersegmented neutrophil, oelocyte, and basophilic stippling. Then folic acid deficiency, you have to remember these causes as well as lab diagnosis in pernicious anemia, aplastic anemia, heredity, spherocytosis, and elliptocytosis. These are the condition in which the cell membrane is abnormal, is lead to these kind of condition, and how you diagnose them. Then heredity pyropoikilocytosis, and then heredity stomatocytosis, xerocytosis, G6 deficiency, and then pyruvate kinase enzyme, which is really important for the production of ATP within the cell. So if there is reduction in the pyruvate kinase, it can lead to destruction of red blood cell. um, it could lead to anemia, then sickle cell disease, hemoglobin C disease, alpha thalassemia. So you have to remember all these causes as well as how to diagnose it. So I put it over here. And beta thalassemia, we'll go in detail about in thalassemia. PNH, paroxysmal nocturnal hemoglobinuria, is a condition in which we have no CD55. Uh, and it's caused the activation of complement system. The cell, the antigen bind with the antibody with cold temperature and cause hemolysis in the warm temperature. And how we diagnose it, I put the test over here, you can remember. And then malaria parasite, and then cold agglutinin syndrome, what is it and how we can diagnose. You can do the direct antiglobin test, and this all about anemias and their causes as well as their main type. So I hope everyone will get an idea after watching this video. So thank you.